So ultrasound diagnostics, what can we see? Has anyone done ultrasound diagnostics before? Nope, no hand. Okay. Yep. So I've done this for about 5 years now, so please, if you have questions, let me know. The images make complete sense to me, but the first time I started, I thought I was looking at a broken TV screen. So if you have questions, ask them, and I can really try to lay that out for you so it makes sense. Okay, so first things, tendons. Tendons is probably the thing I see most. Tendinopathies are really, really easy to see on ultrasound, okay? They're just right in your face, more than MRI. I've actually had a couple of tendinopathies that were not seen on MRI and that are just super obvious on ultrasound. Tendon tears, calcifications is another one. Calcium is very much like bone in that my ultrasound can't pass through it, so I know exactly where it is because it's blocking my image. And then tenosynovitis is a great one that I see a lot of that responds really well to a very quick steroid injection. Pain is gone, rehab can begin. Joint and soft tissue. So joint effusions is probably a very common one that people know with ultrasound. We can see fluid really, really well with those ultrasound rays. And then diagnosing things like bursitis, cysts, Baker cysts, ganglion cysts. We can see all of those with ultrasound. Muscle pathology is very similar to tendon. This becomes very useful for me if I can get them in pretty soon. I can tell partial, complete, is there something I can do sports medicine-wise, or do they need to go to surgery? And then myositis ossificans too. If we let these muscle huge hematomas sit in there for a while, they can calcify and be much harder to heal from for the athlete. Okay, and then nerve pathology. So again, ultrasound is really, really great at seeing nerves and when they're being compressed and damaged. So sometimes, again, better than an MRI. I've had a lot of people who've had a totally normal EMG and MRI for their median nerve. They come to see me. Their nerve is thickened and enlarged on their carpal tunnel, and we can treat that right away. And I'll show you guys kind of the treatment I do for that is very successful as well. That does not have to be surgical. Okay. So getting introduced into our ultrasound images here. All right, so the first thing that we have is, let me put on this little laser pointer. Okay, is bone. So bone is bright like this and nothing passes through it. Okay, so that's gonna be bone on your ultrasound. Next thing we have is muscle. So this is the FHL muscle, and it looks very much to me like a steak. Okay, so muscle does look like that on ultrasound. Third is fat. So fat tends to have this brighter appearance to it, but it looks really irregular versus tendon that has a brighter appearance but is very linear. Okay, so that's kind of your introduction to musculoskeletal ultrasound. And what we see here, so this is actually a pathologic tendon. And so this is what normal tendon looks like here, and this is what tendinopathy looks like. So that tendon gets enlarged, it gets thickened, it gets really, really dark. And really what I'm seeing is those fibers that used to be linear, and ultrasound works through physics, so through refraction and reverberation, if you guys remember those fun terms. Basically the wave comes down, if it hits something linear, it comes back, and I see it straight and bright. When it comes down and sees tendinopathy, that's irregular fibers that have not healed the right way, those rays scatter, and that's what makes it dark. Okay, and so a lot of times what we're seeing for tendinopathy, and we'll see this in some other places, is things get darker, thicker, and that's how we know they're irregular. So this was actually a patient who was a PT, had gone several months without being able to fix their own Achilles tendinopathy, and responded really well to just a tenotomy directly into this tendon. One side healed with one treatment, the other side healed with two, and they were back to activity. Okay? Any questions on kind of what the images look like? Good? All right. Okay. Next thing is ultrasound is able to scan a tendon from its start to finish, and that has also led to some alterations in treatment that you might not think about if you're not looking inside. And so the flexor hallucis longus, for whatever reason, I've had patients that have compression at the three main sites and been able to see those and treat those. So first one is going to be at the knot of Henry. So this is actually scanning the bottom of the foot. And a reintroduction again. So this is the tendon. A patient is actively contracting and relaxing it for me, and it's just sitting in a bath of fluid. So the fluid from the tenosynovitis has been trapped here versus in one of the other locations. Again, this was treated with a steroid just to bring down this inflammation so the patient could start to recover. Okay, next interesting case I had with the FHL was actually trigger toe. I hadn't even known this diagnosis existed until the patient came to me and was triggering. And we can actually see it getting stuck under this pulley system here. So you can watch that toe as it tries to pass through with the patient activating. This was actually a case report I did because I did not think they would respond to a steroid, but I injected this area and the patient did not see me for the rest of the time. So didn't have return of that patient to verify that it went away, but they had been coming consistently to see that PT and then stopped. So a good case where just putting some steroid in there, bringing down the inflammation allowed that triggering to resolve.
What did the presentation look like for that patient? Did they have like a catch in their toe?
Yeah, you could see it trigger just like a trigger finger. Mm-hmm. Okay, and then the third one was actually at the tarsal tunnel. So we have the tibialis posterior there, the flexor digitorum longus, and then the FHL. So here, and sorry, that's the neurovascular bundle. Again, we can see here a lot of tenosynovitis in this area. There was even a split tear of the FHL here. This was actually mine. I could not get onto my toe. Luckily, at this time, I was doing ultrasound. Unluckily, I didn't know anybody who could inject me. And so I had to kind of search for somebody who was willing to get into this area. It's a little bit dicey without ultrasound. As you can imagine, we're getting into that neurovascular bundle. But again, just showing you how a diagnosis of tenosynovitis or even tendinopathy of a tendon can matter where it is, and having a diagnostic ultrasound allows you to get in there, one, see exactly where it is, and then two, do your treatment.
Just like your types of injections, you mentioned a lot like steroid, but do you PRP injections and stuff too?
Yeah, we'll get into some PRP cases as well. Just a lot of times I like to start this off with steroids because a lot of people have a certain feeling about steroids, and I have found that when you're integrating a steroid shot with adequate rehab and strength training, it's a whole different type of tool. So I use it a lot for people who come to me and they cannot move for whatever reason, whether it's a bursitis in their shoulders, probably the most common. Just getting rid of that pain for that person allows them to then do their rehab. So yes, I'll go into all my other fun treatments. Okay. One of my other favorite things that ultrasound provides is actually a dynamic exam. So what we're looking at here is the lateral ankle and the ATFL. So what I'm going to show you here is actually an anterior drawer test on an ankle to see the ligament status, okay? So with this patient, there's some laxity. However, those tendon fibers completely engage. So that lets me know there's not a tear, but a little bit of a strain, if you will. The other thing that I see once I engage is there's a little bit of fluid in that joint as well, okay? So dynamic exam allows you to see more than just the structures themselves. This was important in my life as well because I tore my UCL in my thumb, and I had an MRI where they said everything was normal, but I could physically see my thumb get out of socket. So at that time, there was no ultrasound trained person, but they did the x-ray, the dynamic x-ray to see that my bones were actually separating, and that's what allowed the surgeon to do my surgery. If I had not pushed for that, they would have said, oh no, MRI is normal, you don't need to get anything done. So he had to I had a complete tear of my UCL that needed to be surgerized. Okay, and then for this patient, we actually have a complete tear of the ATFL. So you can see as I do the dynamic exam, I don't see any tendon fibers show up in this area. The rest of this is all subcutaneous and soft tissue swelling from the injury itself. Okay. All right, and then we're going to go into, this is the hamstring insertion at the ischial tuberosity. So we have the conjoined tendon and then the semimembranosus. All right, So again, just to reiterate what I said in the beginning, when we have a tendon injury, it is really obvious, right? Look at how large this tendon is. Look at how black it is. The other thing is, as you try to see the insertion site, it's nearly impossible because that's how many cortical changes have happened from this chronic hamstring tendinopathy. Okay, jumping a little bit into joints. So are you guys familiar? Do you guys read MRIs here? No? Okay. So this is just looking at a knee. We have a little bit of fluid here in the suprapatellar recess. Okay, and then we have a Baker cyst showing up. All right, so Baker cysts are really easy. Again, anything with fluid is great for ultrasound. Ultrasound sees it really well. But here's kind of that classic image you'll see drawing of a Baker cyst. And then this patient even had a little bit of a bony fragment that it made its way into the Baker cyst. So you can see that shadowing that comes down from that calcification, or that in this case it was a piece of bone. So really cool things that we can see on ultrasound and diagnose. This was a patient that his Baker cyst was palpable to the naked eye, visible to the naked eye, and my ultrasound couldn't even see the full extent of it. And then we ended up pulling out 100 cc's. So just a huge amount of, range of motion improvement. This guy could barely get past 90, and he was a very active person and had not had that for years because nobody wanted to drain his Baker cyst. And then 2, just pain relief from that. This is a lot of pressure in the knee. Okay. This is a fun one I always like to talk to people about because it was another diagnosis I didn't know about until I saw it for the first time. So has anyone heard of a Morel-Lavallée lesion? Okay. So it is an internal degloving that can happen. Most commonly it was known post automobile accidents, but now we're starting to understand more and more that these happen with any type of traction injury where there's kind of contact and then a slide. The paper I referenced when I first learned about this was actually in football players at their knees. So they were having these internal deglovings there. And then the hip is the next most common site. With my patient, it was actually on the shin from a rugby game. Somebody had stepped on them and then she tried to pull her leg out and caused that internal degloving. So here we have the greater trochanter. We can see the muscle layer, and then this fluid is trapped between the subcutaneous and the muscle. Okay, so that's an internal degloving. Treatment is to drain that or else it can calcify and get stuck. And then kind of to compare, this is when we have a muscle tear itself. So we can see now that this is separating muscle to muscle layer. All right, so again, important to know what is actually swollen underneath that patient. So this one in the hip will easily get confused as like, oh, this might be a bursitis, right? Because where else would we see ballotable fluid? It could actually be a Morel-Lavallée lesion, and the mechanism of injury would hopefully tend you towards that way, and hopefully towards someone like myself who can drain that for them. All right, and then getting into nerves. So when nerves get abnormal, they do a couple things. One, they grow in size, so they get really, really big. And then the other is they get darker, okay? And so this is just a depiction of nerves. So here's the carpal tunnel median nerve. See how small this one is? And versus this one. So this is a nerve getting compressed at the carpal tunnel where we can actively see that on ultrasound, and we know exactly where to treat. Just like the FHL, nerves can be compressed in multiple sites, as we know. And so with my ultrasound, if I'm looking at the median nerve and I'm like, hey, where is this compression actually happening? We can look here, we can look at the elbow, we can even look at the brachial plexus and see if that's the source. That treatment, has anyone heard of a nerve hydrodissection as treatment for a compression? Good. So 1 nod, yes? Yes. Yes, 2 nods. Okay. Yeah, so super, in my opinion, much easier procedure to do than having to go and get surgery. So basically what I do is I have to free that nerve up from all the compression sites. So this is just freeing it up underneath. Another image, freeing it up over the top. It's really hard to capture videos when you're doing nerve treatments because you don't want to mess it up. But this is basically you free it all around, and then a lot of times I'll pair this with nerve flossing or like have the patient do some at-home cupping as well to try to keep that nerve moving.